कौन? ये आप कहाँ देख लीजिए। हाँ। दो दो फील्ड में। रोटी क्यों बना दो? मैंने बोला दो एयरलेट का बना दो। उसका आयुष्मान के बच्चे के पीछे से होता था उसका बना। ठीक। लंबा पीछे रहती है। नहीं ना। तो ट्रांसफर नहीं होगा कहीं का। हाँ। नहीं भाई मैं तो आ रहा हूँ। क्या हाल चाल? कैसे कैसे करना? बहुत ही जल्दी फोन की जगह दोस्त मंदिर
A very warm good morning, everyone. So today we have gathered here for Mortality Meet November 2025, and I am from Department of Hepatology, Dr. Shreya. Last month's total admissions in ICU were 129 and total deaths were 35. So this is the first case of ALF. So case 20-year-old male, 90 kgs by weight, BMI of 31.14, presented with complaints of a fever for 7 days, pain abdomen for 4 days, vomiting 4 days, followed by jaundice since 2 days and altered sensorium 1 day. So his initial assessment in ER revealed a heart rate of 62. His GCS was poor and had a MAP of 110. Saturation was 84% on room air with tachypnea. So he was intubated in ER in view of respiratory distress and poor GCS. Liver span was 18 centimeter, and also he had left basal air entry decreased. His initial investigations in the emergency revealed a TLC count of 39,000. INR was 1.81, ammonia of 502. Total bilirubin was 27 with AST ALT of 1500 and 3100 with albumin of 3.23. Creat was 6.2. His ABG revealed a PF ratio of 392 and lactates were 1.8. His IVC was collapsible. IV fluids were given in ER and his ONSD was 0.62, 0.60. He underwent the scans through the ALF corridor. CT brain did not reveal any features of cerebral edema. CT thorax showed bilateral pleural effusions with partial collapse and consolidation of both lower lobes. NCCT whole abdomen revealed a enlarged liver, 18 centimeter, with diffuse reduced attenuation and no ascites or perihepatic fluid. Liver volumetry was 2004. First, so working diagnosis that was made was a hyperacute liver failure, likely viral related. Jaundice to HE time was 3 days, and MELD was 34, SOFA 14, KCH was 2/5. Current issues were type 1 respiratory failure with moderate ARDS with PF ratios of 170, HE grade 3, and he was intubated for the same. He was in Aiken stage 3, non-oliguric at the presentation. So day 1 at ICU, 12 hours post the day 1 in ICU after initial hydration and CRRT initiation, he was severely volume contracted. IVC guided hydration was done, and which showed initial improvement. And in view of hypercytokinemia and hyperammonemia, CRRT was initiated at 25 ml per kg per hour. And post 12 hours, he had a PF ratio of 274. His MAP was higher and a pulse rate of 110. Urine output was 35 ml per hour, and INR ammonia was 1.88. So this was after the first 12 hours. It was 1.88, and ammonia was 333. And the first session of Plex was done, following which the INR further went down to 1.31 and ammonia to 309. The counts also decreased from 39 to 42,000, and enzymes were also settling. Creatinine came down from 6.2 to 4.81. He had hemoglobin drop from 12.7 to 9.2 on day 2. So he was hemolyzing. He was G6PD deficient and had an H score of 222, secondary HLH. So all his other investigations showed HAV positive. His PCT was high. He was already septic. And his urine RM showed RBCs, which were full-filled, likely possibility of acute glomerulonephritis. And his LDH and ferritin were also high in the range of 6,000, and H score was 222. Post 24 hours of CRRT and Plex, patient had worsening PF ratios, but there was improvement in cerebral edema and INR. So his MAP was 130. His urine output had dipped, PF ratios were worse, and INR ammonia, although was showing improvement gradually. So in view of worsening PF ratios and hypercytokinemia, tachycardia and hypertension, high cytokine CRP ferritin levels, first session of cytokine filter was applied, which was followed by a second session on the consecutive day. So post the first session of cytokine filter and post second session, so there was improvement in PF ratios to 345 and 327. His heart rate also started to settle, and his INR was although 1.8, 1.9. Ammonia had started to settle, 250 to 180, 188. TLC counts, which are initially 42, came down to 52 and then to 37,000. So they had started downtrending. Post cytokine filter, PF ratios improved, hypercytokinemia also improved, and TLC also shows improvement. CRRT dose was escalated to 40 ml per kg per hour, and the INR ammonia was continuously in downward trend to 1.66 and 151 on day 4. Day 5, he was switched to Oxiris filter. His TLCs had further decreased to 26,000 now. INR was also settling, and PF ratios were better. On day 6, his TLC decreased further to 19, and INR ammonia was further improving, and PF ratios were all stable. However, he had third spacing of fluid with nil urine output. So ultrafiltrate was started at the rate of 10 ml per hour and gradually increased to 20 ml per hour, which he tolerated well. But on day 7, he had worsening PF ratios to 150 with new infiltrates in lung and effusions, which was non-tappable, and a VAP score of 6. FiO2 requirement had now increased from 40% to 70%, and antibiotics were escalated. On day 8, in view of his PF ratios further worsened to 120, a third session of cytokine filter was applied, but there was no improvement in the PF ratios, following which prone ventilation was initiated for the patient, following which his FiO2 requirement started to decrease, and it came down to 40%, 45% in the next 16 hours, and PF ratios were 275. However, when he was deprone, he had rapid worsening of FiO2 requirement. Day 9, his PF was 128, which gradually increased from 45% to 75% after deproning. CRRT dose was escalated, Oxiris filter was applied, but PF ratios still remained poor, 273. Second session of proning was done, following which PF did improve to 375, and FiO2 requirement decreased from 100 to 75%. But after deproning, again, the PF ratio started to worsen. Third session of proning was done, but this time PF remained poor. patient's family was repeatedly being counseled at the same time for ECMO facility, but it was not available at our center, and therefore we had made arrangements to arrange ECMO at our center, for which a specialized team was also called. As per the guidance, a bronchoscopy was done by the team for the patient. However, the procedure had to be abandoned in view of profuse mucosal bleed. Considering the bleeding risks, which could not be corrected by coagulation correction, the team deferred from applying ECMO for the patient, and thus he could not sustain the next 6 hours and collapsed. Similar case, there's a second case of ALF. A 20-year-old male with a BMI of 26.14 with comorbidities in the form of seizure disorder had fever for past 10 days with yellowish discoloration since 6 days, vomitings 4 days, and altered sensorium 1 day. His initial assessment in ER revealed a poor GCS with a MAP of 110. His saturation was maintained, but in view of poor GCS, he was intubated in ER. His initial labs showed a platelet which was preserved 355 and his hemoglobin was 16. INR was 2.24 and ammonia was 280. Enzymes were in the range of 2000s and bilirubin was 11. His creatinine was normal 0.86 and his PF ratio was 240. Lactates were high for him 6.3. His IVC was non-collapsible, non-distensible, and there was a mild right effusion also, and his ONSD was 0.54 and 0.52. He underwent scans. The CT brain showed no features of cerebral edema. CT thorax showed bilateral mild diffusion, which was noted right more than left, with passive subsegmental collapse of the underlying lungs. His liver was enlarged, 23.1 centimeter, normal in outline, diffuse hyperattenuation. No evidence of focal lesion was seen. GP wall edema was also noted. Liver volumetry was 1850 centimeter cube. So his first day in ICU, so hyperacute ALF, acute is viral related, jaundice to HE was 6 days, MELD of 34, SOFA 14, and KC at 0/5. He was intubated in view of HE grade 3-4, and he had septic shock with lactates of 6.3. He had AKI KDIGO 3. He was initiated on CRRT. He also had oliguria. On day 1 at ICU at 12 hours, there was the lactates had started to clear, but there was worsening PF ratios from 277 to 98, following which the CRRT dose was escalated and PF started to improve in the next 24 hours and PF improved to 165. The INR also was downtrending 2.06 and ammonia was downtrending to 350. On day 3, he had worsening shock and PF ratios further deteriorated to 105, following which the CRRT dose was escalated and switched to Oxiris filter after MAP stabilization, and INR ammonia showed a downward trend further to 1.49 and 286. Day 4, PF ratios improved to 270 and FiO2 requirement also decreased to 60%. Shock and vasopressors were also tapered. INR ammonia were also showing downward trend. Following this, Oxiris was further escalated and PF ratios continued to show improvement and FiO2 requirement decreased to 40%. Patient remained stable over the next 5 days, during which aggressive weaning trial was given for him. However, he could not be weaned off ventilator. On day 11, he had worsening PF ratios to 156 in view of new infiltrates in the lung with effusion, likely VAP-associated pneumonic effusion, score of 7/9. Antibiotics were escalated. Single-time aspiration of the pleural fluid was done, which revealed low SPAG, high protein, and neutrophil predominant counts. Likely bacterial effusion. Therapeutic bronch was also done, which revealed pale blood-stained thick mucopurulin secretions, etiology of which being likely bilateral bacterial and fungal pneumonia. Bile culture revealed Cryobacterium positive. PF improved to 342 after STA after single-time aspiration and bronchoscopy to 342, and FiO2 was tapered to 40% over the next 3 days. On day 15, again, he had worsening PF ratios to 140, 120, following which cytokine filter was initiated and proning was done. His PF improved to 375 over the next day, and dose of Oxiris was also escalated to 40 ml per kg per hour. On day 17, PF ratios further improved. So there was this new onset infiltrates which had come up, which was the reason for the new worsening. And day 17, the PF ratios improved to 320 and FiO2 requirement decreased to 50%, but vasopressors were initiated in view of new onset septic shock, and blood cultures showed Enterococcus positive. Antibiotics were upgraded and Oxiris dose was also increased to 35. At day 20, this was the new cause of worsening. The chest X-ray showed new infiltrates and HRCT thorax was done. 21, today, he had a fever with worsening shock. Second side of cytokine filter was applied and antibiotics were upgraded. Patient was stabilized over the next 2 days. On day 24, PF ratios further worsened to 122 and prone ventilation was initiated. Following which, the PF ratios improved to 320. And post-reproning, FiO2 was gradually tapered to 35% and shock also improved. Patient remained stable again over the next 3 days, during which aggressive weaning trial was given. However, he could not be weaned off ventilator. On day 28, he had worsening PF to 144. Again, prone ventilation was done and PF improved to 350 over the next 16 hours. Post deproning, his PF decreased to 285 and was at FiO2 of 85%, which was tapered to 60% over next 1 day. Yes, sir. So he was tracheostomized on day 29, and there was poor PF ratio, following which he received a fourth trial of proning. And ECMO was also given as an option, but the family could not move the patient to another setup. Therefore, he had worsening of shock. ECMO could not be applied also. And he had worsening of shock on day 30. There he was on triple vasopressors. And he finally, and a salvage therapeutic bronch was done on day 34, following which the PF ratios improved, but his shock started to worsen on day 36, and he could not be salvaged. On day 38, he collapsed. So the issues to discuss. So these two ALFs that we have discussed, the INR ammonia was improving. So liver as a whole was recovering, but patient mainly died and collapsed because of sepsis. So this was a second hit sepsis in ALF, which became the cause of death for these two patients. So we will be discussing about the second hit sepsis in ALF, data of infections in ICU, strategies to prevent sepsis, and ECMO indications and contraindications. So what is second hit sepsis? The first hit we already know is the acute liver failure. So the massive injury, hepatocellular injury that takes place, which causes SIRS immune dysfunction, endothelial activation, following which once this second hit comes in, so the ICU acquired infections, which are mainly bacterial or fungal, VAP, CLABSI, COTI, catheter-related fungemia, line sepsis. So all of these are the second hit, which results in exaggerated systemic inflammation and multi-organ failure and increasing vasopressor supports and CRRT need, and thus can preclude or delay liver transplant and thus worsen ICU and waitlist mortality. So the ALF specific risk factors for this sepsis is the immune paresis and monocyte dysfunction, which is ammonia driven, high ammonia and cerebral edema, which results in altered sensorium and increased aspiration risk, the multi-organ failure, and the frequent use of catheters, the central line, the catheter associated UTI, and also the use of CRRT. So all of these invasive procedures that needs to be done in ALF increases the risk of second hit sepsis in these patients. Intubation for grade 3-4 HE, again ventilator associated infections, other major risk factors. So second hit sepsis and ALFs, these are the studies. So in 2024, Venkata Krishnan, he had shown that 66% bacterial infections were found in ALF and 33% fungal. In 143 patients which were studied in 2023 by Kaur, had shown a 76.9% infection, bacterial infection, 17.3% fungal infections. In this study in 23, 40.7% bacterial infection, 16.2% fungal infections. And in the Ronaldo trial, 1996 is the oldest one, 80% were having bacterial infection, 32% fungal. So bacterial infections ranges approximately 40 to 80%, and the fungal infections 17 to 30% in ALF patients. Timeline of infections, if we consider via this Ronaldo et al. Trial. So in the initial day 0 to 1, the ALF diagnosis, there is immune dysfunction. From day 2, the UTIs appear. And day 3, bacteremia kicks in. Day 5, pneumonia sets in. So VAP, ventilator-associated pneumonia, classic second hit with respiratory failure sets in. So distribution of infective episodes. So pneumonia is seen in 50% of episodes, and bacteremia and UTI in 20 to 25% of each. With early systemic antibiotic, infective episodes were seen to decrease by 20%, and overall mortality also decreased to 44%. This is not ALF specific data, but ILBS data on positive growth that is seen in samples. So about 19.3% in September and 14.3% in October. And we talk about blood samples, it is 54% positive samples, 26% in respiratory samples, and 20% in urine samples. And 31% was out of the total patients who were admitted, 31% had infections, and 18.4% in October. So considering this, what are the preventive measures that we should take in hand to prevent infection? So first is hand hygiene, which is very important, which can decrease the rate of infections by up to 50%. So that is the first most important step. And in ILBS, the study that was done, the hand hygiene was the most poor in doctors. So in September and October, it was 74% and 57% respectively. So hand hygiene is the first important step to be taken, following with standard and contact precautions, gloves, gowns, masks, all that needs to be taken. environmental cleaning, disinfection needs to be done at least twice daily, and the checklists needs to be revisited again and again, whether the up-to-date disinfections are being done or not. Staff cohorting. So this assigns staff by colonization or infection status. So we should cohort nurses for carbapenem resistant or VRE patients, minimize cross coverage between MDRO and non-MDRO rooms. 1:1 nursing should be provided for ALF patients. Device days minimization, remove early principles. So here, the daily device check round, indications for CVC, Foley's, NG, arterial lines should be daily checked, and should be removed when it's not essential. Staff education and feedback, so regular training and dashboards. So monthly hand hygiene, CLABSI, evaporate should be displayed, and training should be given, and airway care should be advocated. So that is the first. Then recommended timelines for ALF ICU device. So I had search extensively through the literature, but there is no specific timeline. All they have advised is dressings should be changed every 48 hours, and transparent dressing should be applied every 7 days or earlier if soiled or loosed. And the catheter change should not be done on a routine basis. It should be done only if there is suspected catheter-related bloodstream infection or there is purulent exit site infections, malfunctions, accidental contamination. Arterial line dressing should be changed every 2 to 3 days or sooner if damp or loose. No, if damp or loose. Catheter replacement should be done. Often, practical ICU policy would be often 5 to 7 days maximum for Radialine if still needed, or earlier if waveform is poor or suspected infection. Study shows infection risk does not increase clearly over first 7 to 10 days. Then peripheral IV cannula. Again, this should be changed only when clinically indicated, when there is pain, phlebitis, or any suspected infection. Dressings should be changed. Even CRRT dialysis catheter dressing should be changed every 7 days, and they should be examined on a daily basis. Catheter replacement should not be done on a routine basis, only if indicated. And Foley's catheter should also be changed only if indicated. There is no fixed timeline for the same. Change only when obstruction or back tubing breach or encastration or COTI is there. Then drainage bag also replace when visibly soil leaking or per manufacture. No fixed 3 to 5 day requirement is there. Only if it is leaking or if it is soil, it should be changed. NG tube should be replaced every 4 to 6 weeks or earlier if blocked or dislodged. Alternate nostrils when replacing. And position or safety check should be done before each feed medication, and after coughing, vomiting, or accidental pulling, it should be checked. Bundle of device related infection prevention.
Shreya, you have a long list. Can we go back to the patient and see what better could we have done in this? I think unless you have something very high new information, anything else we could have done in this patient to save?
So
You have 4 points. One is the infection. Go back to
Yes.
that slide where you have 4 issues to be discussed.
yes, sir.
So one is second hit, second is data, third is strategies, and ECMO. What do you think? Was the patient justified for ECMO, and should we have ECMO here?
So we could have applied ECMO, but on time, because the ECMO was already delayed because the setup was not available at our center, and then we had to call the team. So that took about 24 hours delay was there, and by then the patient was already sick.
It's
So-
severely coagulopathic.
Yes, sir.
And, I talked to the team there. They said ALF. Are you showing something? Please go ahead.
Yes, sir.
Briefly.
So ECMO in liver patients. So veno-venous ECMO, veno-arterial ECMO, and veno-arteriovenous hybrid ECMO. So this is basically the veno-venous ECMO which we do for patients who have a bad lung and a good heart. And for patients with a bad heart, veno-arterial ECMO is done either peripheral or central. So why we should consider ECMO in ALF? So in ALF and even in ACLF, who are complicated by severe ARDS and circulatory failure, peritransplant. So this should be offered in peritransplant period, where massive hemodynamic shifts and risk of cardiac or respiratory collapse is there. So as ECMO can act as a bridge to decision or bridge to transplant in carefully selected patients. So its indications are a refractory hypoxemic respiratory failure in potential LT candidates, cardiogenic or mixed shock not responding to vasopressor inotropes, that is cardiac failure. So they should be receiving the veno-arterial ECMO, and peri-LT rescue, intraoperative salvage, or post-LT cardiopulmonary failure. Now, timing is very important. Early deployment in potentially reversible pathology with a clear plan of bridge to LT or recovery. In ALF, it is usually only if emergency LT is feasible and imminent. In advanced ACLF without LT option, ECMO is often futile due to extreme mortality. Major contraindications would be irreversible neurological injury, uncontrolled sepsis, or uncorrectable coagulopathy, which in his case, he had because it was already delayed. So by that time, his INR had also started to rise. But when he was advised ECMO, that time his INR was also okay. His rotum was also perfectly fine, and he was not bleeding at that time. So no realistic transplant option and multiple non-recoverable organ failures.
We have to conclude. Our time is running out.
Yes, sir.
So going
These
back
were
to
the
any
studies.
comments from anyone?
Told. Are we adhering to all that or they are only here? I just want to know. What is the ratio, present ratio, and all those recommendations which were you showed?
Present,
Are we or there is a need for improvement?
So definitely we need to improve, sir. And I didn't get the question, sir. Ratio of
What
infection.
is the present nurse patient ratio?
Sir, it
Because
is
it should be
1:2,
1:1. So
Sir, it is 1:2, or sometimes also it goes to 1:3 also at times, but it is never 1:1. And for ALF patients, once if the nurse is given other infected patient, then she might infect ALF patient also. So at least for ALF, for precious patients, we should at least have 1:1 nursing ratio.
Vinay?
Hi, sure. I'm just going to make 2 points actually, and I'm going to drift from, what you have shown. I'm going to just drift from those territory and then talk about something I think which is very important now. Good presentation. So this is a point about sepsis in ALF, right?
Yes, sir.
In the current era of ICU management in an ALF patient, or for that matter, other patients as well. So we do have measures sorted out for cerebral edema. We do have measures for liver failure, right?
Yes, sir.
So you're doing CRRT, you're doing PLEX. So the numbers of those failures will not show up on your chart, right? So the only thing which is going to show up is sepsis, right? This is the only thing which is going to kill ALF patient currently, because others you are supporting. You have support measures for liver failure, you have support measures for cerebral edema, and the 2 major causes of death in ALF patient is cerebral edema and sepsis. So sepsis is what it is going to show up, right? So it brings back to the original question of what criteria we are using to transplant this patient. So we are still stuck with King's, and King's actually doesn't include infection, SARS, sepsis, and also grade of cerebral edema in their criteria. So are we actually following criteria which are not updated to the current era of management of ALF in ICU? I thought that's the basic question which need to be answered, because this is going to happen again and again. This is not going to just go away, because the type of support system we are taking or giving to the patient in
The
ALF.
point is, should these patients have been transplanted early? At least one of them I know we had referred.
No, both
Uh,
were referred for transplant.
at-
Both have no.
Both were
No.
referred.
So every almost 40 to 50% of the patients who come to us don't have donors also. So it's not that we are not referring; they don't have donor.
No, don't take it otherwise. I'm
No,
not
we are
saying
saying that
referral
it's not
population.
that
My point
transplant
is-
was not. We would have offered a liver transplant.
Rakhi, and I'm not playing a blame game here. Please don't take
This
it
patient,
otherwise.
let's stick to the point because
That's
there was
what
no
I'm
transplant
sticking
option.
to.
That is why all these
The
this is
criteria being used, are we, because now you're presenting that you need an ECMO, right? ECMO will support lung, but sepsis won't go away, right? So we will just keep adding organ support system, but we are not actually addressing the core problem, root cause problem. That's where we're stuck. And that's, I think we need to think about how we need
So
to.
we need a disease donor program for that matter,
Yeah.
and we should discuss that if a live donor is not available.
Yeah.
Because we haven't
second point-
denied a transplant in these patients.
It's not denying, it's about, transplant logistics are always problem. So second important point I'm going to make, which is actually very relevant in the context, because we are having same problem as well. So you got patients here who had somehow liver has recovered, but lung has taken the hit, right? We also had quite a few patients actually where the graft functions were very good, but the lung took a hit after 7 to 10 days of transplant. And some of those actually we didn't grow anything as well. We didn't, the classical pictures were of fungal sepsis on CT scans, on X-rays, and the patient was behaving like a septic. But some of them we didn't grow anything. So are we somewhere missing out something? that
It's
there is something happening
always
which is not
there.
really been picked up by
To
us.
be brief, we are not able to find the organism or the fungus in time. And therefore, the empirical rules are there.
Would you,
And
so can I just make a point?
yeah, please.
Shreya, would you like to say your challenges in the ICU with the limited doctors also? What are your challenges with respect to the microbiology support, the support of the staff, the support of the other things in managing such difficult patients? Because there are 28 beds and 2 people.
Yes, sir.
To manage all these tough patients, proning, all these things require adequate manpower also. The other thing is when you show the ECMO, so the problem with both cases was the ECMO was told at least 6 days prior to when they succumbed. And by that time, the coagulation and everything, because first is because we don't have a facility in hospital, we don't counsel them that rapidly. But once we start proning one session, next session, we obviously counsel ECMO. So that is a point we counsel.
Is well
And-
taken. I
And
think
so
these are.
because we are having ALFs which are recovering, and these patients would have recovered. They both
Okay.
were doing quite well.
I'm
and
not
just
sure
oxygen
what is
support-
the idea of presenting these two cases here. The idea of
The idea is, sir, we are losing our
Not
ALF
sure.
who are recovered. And again, so the problem is 38 days of stay in the ICU. Every 3 days they are better, they get a second hit, and every 3 days they are down. So that is the problem, sir.
Well, okay, thank you, Shreya.
Small
Good
observation.
job, and,
Suggestion.
yeah.
So what we can do that, Rakhi, the simplest thing we can do right now in our current setup with all the constraints. So we can do cohorting actually. The ALF patient, so when they come, so we should not put these patient with other patient who had a long hospital stay. There is a easiest and the simplest thing we can do. We can make one cubicle, no, sir, we are.
If I'm suggesting 1:1 nursing, sir, I requested also, so this is the way, because at least we can improve some. These patients can be saved. These are young patients, and it's just about preventing these deaths.
For
That's what I'm saying.
220 beds, ILBS probably has the highest number of nurses, 450 plus. You can ask anywhere, any hospital. So don't say that. Maybe the deployment is not correct. That can be looked into. And I'm not
One
sure this is
mission-
the forum, morbidity, mortality is to discuss nurses ratio or doctors ratio. Here is what the patient needs. If you need ECMO, let's say what are the guidelines? Which patient needs an ECMO? Okay, thank you, Shreya.
Good morning. I will be discussing about the mortality and morbidity of October and November from HPV surgery. So in October 2025, we did a total adult living donor transplant 13 and pediatrics 12, 2 liver transplants were done. Total of 15 liver transplants were done. In November, we did a total of adult living donor transplant 8 and pediatrics 2 and 2 DDLTs were done out. So in total, 12 transplants were done this time in November. Total mortality, coming to total mortality, the total transplants still now are 157 and mortality total 27, that is 17%, and 30 days mortality about 19 patients, which is around 12%. So elective surgeries done in October 2025, total of 34 laparoscopic cholecystectomies and major resections, like 1 major heparectomy was done, 2 extended cholecystectomy, and other surgeries like non-anatomical resections, 1 was done, and CDC excision was done. 3 hepaticogynostomy and 3 Whipples were done, and few other this laparoscopic headed cyst deroofing, there were 2 done, and umbilical hernia and incisional hernia repairs around 3 were done. In November 2025, we did a total of 32 laparoscopic cholecystectomy and 4 extended cholecystectomy and 1 major hepatic resection, and 1 Kasai portoenterostomy was done in 3 hepaticogynostomies, and 1 Whipples was done, and around 3 this splenorenal shunts and splenectomies were done. So in emergency surgeries, in October, we did 1 incision and drainage for abscess, and then other this exploratory laparotomy and ileostomy was done 1. And in November, we did 2 exploratory laparotomy and 1 exploratory laparotomy and ileostomy. So before coming to this mortality and morbidity, I would like to share some achievements. This time we did Asia's first DCD NRP liver transplant, which was the liver was from Manipal Hospital, Dwarka. The patient was kept on normothermic regional perfusion, and we did a transplant. And then Mr. RN, who was a 48 years old male, we did diseased donor liver transplant and with the right tube thoracostomy, and he was discharged on post-op day 14 with stable immunosuppression. So, and we did an outstanding performance in this LTSI conference where Dr. Sahil Gupta, assistant professor, got best video presentation, and Dr. Naren and Dr. Raj Gopalan got best presentation awards.
A big round of applause for both the achievements to the students and the team. Go ahead.
So another patient I would like to quote here was Mr. VB Singh, who underwent living donor liver transplant for ALF HBV related on 10th of September 2025. He had delayed neurological recovery and he was barely able to lift his head and even not able to flicker his fingers. With the support of transplant team and nursing staff and physiotherapists, now he's improved and he's able to ambulate with support, and we are planning to discharge him in a day or two. Coming to morbidity, we had patient Mrs. MS, who was 48 years female, who CLD HBV related, and we did a living donor liver transplant with the right lobe, and she recovered well and had intraportal vein thrombectomy was done and ICD was placed, and right splenic artery ligation was done for aneurysmal dilatation. In post-op period, she had a SSI with fungal growth, and there was rectus dehiscence. So she, on biopsy, it was found to be rhizomucor species. So she was well managed with regular dressings and serial debridements, and she underwent secondary closure on 29th of October, and then she has been discharged now. So another patient, the same patient, Mr. VB Singh, had for acute liver failure for HBV related. He was in single criteria KCH. Now he's had delayed recovery, neurological recovery, and with regular physiotherapy, and he's now planned for discharge. Coming to mortality of October 2025. We had Mrs. SB, which is 60 years female, CLD NASH with autoimmune hepatitis, and post parto for on October 24. She was having comorbidities, diabetes, and she was on OHS. She underwent living donor liver transplant with left lobe with MHV, the umbilical hernia repair on 22nd of September. And she was the cause of death was cardiac. She had cardiac arrhythmias and biphasical block, which due to which she had cardiac failure and led to bilateral pneumonia with sepsis. And then antecedental cause was metabolic acidosis, which was uncompensated, and she later on had DIC and refractory shock and acute kidney injury. Then another patient, Mr. HS, which was 47-year-old male, CLD ethanol, and he with a MELD of 23. He underwent liver transplant in July 2025. He was there in ICU for a long period. He had this hepatic artery thrombosis on for which he underwent DSC and thrombolysis on 11th of August 2025, and angioplasty was done on 13th of August. He had bacterial and fungal. He had bacterial and fungal pneumonia, which led to septic shock and then sepsis-induced graft dysfunction and acute kidney injury, and the patient succumbed to death later on. Mr. RSK, who was a 56-year male, He was a post-transplant patient admitted to our side for with the we did a right in transplant. We did a right graft with cable resection with PTFE and cable replacement and umbilical hernia repair. He was having biliary issues and with cut surface collection. We did PCD. And he underwent PTBD later on in August 2025, and PTBD was exchanged on 12th of September 2025. After which he developed intrahepatic artery, which was not visualized on, and there was focal hypodense lesions in the liver on the scan, which was done next day to PTBD as his test was his liver enzymes were increased. They tripled, liver enzymes tripled. So he developed cholangitic abscess, and later on he developed ascites, right pleural and coagulopathy. So he was later on he developed bilateral bacterial and fungal pneumonia leading to septic shock, and the antecedent cause was post PTBD exchange cholangitic abscess and hepatic artery thrombosis. Mr. SSU, who was acute necrotizing pancreatitis with peripancreatic collection, we did CT. He was being managed on step-up approach, but he could not be saved because of respiratory failure and sudden cardiac arrest was there, and he had aspiration pneumonitis, and contributing cause was acute necrotizing pancreatitis. For month of November, we had total 3 mortalities in post-transplant patients. One was Mrs. RG, who was 40 years old female, Carol's disease with bilateral hepatolithiasis, and with the MELD of 31. She was transplant was done the left lobe graft with Codate on 16th of October, and there was IVC cross clamp and portocaval shunt was made during transplant intraoperatively. There's the immediate cause of death was bilateral pneumonia, which was fungal picture, which has fungal picture on CT scan and X-rays, but there were no organism could be isolated. Her cultures were all negative. Then she developed multi-organ failure, and then the acute kidney injury and anuria, coagulopathy, and she had upper GI bleed and clinical rejection. After that, then she had sepsis, which was refracted to, refracted. We had Mr. AC, 44-year-old male. We will be discussing this mortality in detail. He was CLD ethanol patient with the MELD of 29, and we did a ABO incompatible liver transplant after 1 cycle of rituximab. So intraoperatively, there we made a portocaval shunt and a left renal vein ligation and a left gastric vein ligation. Later on, the patient had multi-organ failure, and multi-organ failure due to invasive mucormycosis, and bacterial and fungal pneumonia was there, and then he had sepsis-induced graft dysfunction and acute kidney injury, which required CRRT. So Mr. AG was 49-year-old male, CLD autoimmune with NASH. He had a MELD of 22. He had severe sarcopenia, and he did a right posterior lobe liver transplant with umbilical hernia repair and right inguinal hernia repair on 28th of October. So he had a multi-organ dysfunction syndrome due to severe septic shock and bacterial and fungal pneumonia and CMV viremia. So coming to Mr. AC, we will be discussing this mortality in detail.
Very limited time because we have nephrology after you. So just highlight the recipient and post-op. Go ahead quickly.
Mr. AC was he had no comorbidities. He had no past surgeries. We did a transplant on 13th of October. So he had index presentation in 2022. After which he was referred to ILBS in January 2025 from outside, and in 2025 April he was admitted in hepatology and for hepatic encephalopathy, and he was later referred for LT. initially had no prospective donor, and later on his father-in-law came as a donor. In multiple hospital admissions before the donor could arrive, the father-in-law was a donor who was, but it was ABO incompatible. So we did a rituximab therapy on 10th of August, and workup was completed in July 2025. In August, then after rituximab, he had he had pleural effusion, and which was suspected to be infective etiology, but it was negative for tuberculosis. He was admitted for liver transplant, underwent PLEX on 7th of this September. Post PLEX, he had fever and chills with tachycardia. So ICD insertion was done, and he was later found to be influenza positive. LT was deferred, and then he underwent liver transplant after optimization on 13th of October. In preoperative workup, he had this viral markers were all negative, and he was fine. Preoperative workup had the room air PO2 was 79.5. Chest was having bilateral pleural effusion, is left more than right, and he had raised creatinine 1.38. So donor was Mr. JS, who was his father-in-law, and he had no comorbidities, and viral markers were all negative. USG liver attenuation index was plus 13, and FibroScan was fine. He was optimized, and liver volume was from right. He was in so we did a liver left lobe transplant. 478 was estimated volume, and 0.74 GRW was there. This arterial anatomy was favorable, and he underwent. So in our patient, preoperative problems were he was decompensated CLD with who was diagnosed in 2022 and came for liver transplant in April 2025, and he was ABO incompatible liver transplant. Workup was completed and authorized in July 2025. Recent multiple hospital admissions for LVP, HE, and hydrothorax, and post-PLEX influenza, which was optimized and treated. So intraoperatively, he had ascites of 4.5 liters, and liver was shrunken and macronodular, thickly collateralized triangular and coronary ligaments were noted. Adhesions were noted between the omentum and gallbladder. Adhesions were done, and arterial anatomy was classical. Hepatic veins were normal. So he underwent LDLT with caudate lobe, left lobe with caudate, and portal vein anastomosis were left portal vein to main portal vein. There were two arteries were there, segment 2 and 3 artery, and segment 4 artery of recipient two recipient RHA was anastomos. He had this single duct anastomosis. Intraoperatively, temporary portocaval shunt was made, and left renal vein ligation was done, and left gastric vein ligation was done. Aneuploidy phase was 99 minutes, and portocaval shunt time was 117 minutes. He had cold ischemia time of 65 minutes, and warm ischemia time of 64 minutes. He had estimated graft volume was 478, but we got 402, and GRW was 0.59. Overall blood loss was 4,000 ml, and we transfused 8 PRBC, 8 cryo, and 6 FFPs. So post-op Doppler was intraoperative Doppler was normal. So in post-operative course, he was shifted to transplant ICU on BOD0 and ventilated support with dual inotropic support. And he had deranged sugars and high lactates, which on POD1 inotropes were gradually tapered, and he was extubated. Doppler was normal. He had a decreasing trend of lactates. On POD 2 and 3, his graft functions improved and lactates were normalized. He had hemorrhagic drain output, for which PRBC was transfused. In chest X-ray, there was right-sided haziness with pleural effusion. POD 3 cultures were no growth, blood, urine, and drain. All were showed no bacterial growth. On POD 6, he had postoperative ileus with high NG output, but it improved with bowel rest. In he had thrombocytopenia, for which one SDBC was transfused, and there was hemorrhagic drain output, for which one more PRBC was transfused. And he had borderline urine output, and blood culture showed VRE, for which antibiotics were upgraded.
You have to summarize somehow. We are very late. What was the main issues of his cause of death?
Sir, main issue was he was having ileus, for which we did a CT on post-op day 16. He was
He shows the graft functions.
so graft function was good. He was after having ileus, and then we did a CT. We decided to do exploratory laparotomy. He was on exploratory laparotomy. Gangrenous distal ileum segment was there around 80 centimeter, which was extended to ICJ. And there were ischemic changes in the terminal ileum and ileal mesentery. So this was the bowel we found intraoperatively, and on pathology it showed fungal invasion, which was found to be mucor, and the fungal was angio-invasive into the blood vessels. So later. The resected segment of the bowel, which was gangrenous, had ileal segments with invasive mucormycosis, which was admixed with gram-positive cocci and patchy mucosal small fragments to acute transmural hemorrhagic necrosis was there, and consisted in gangrene and acute or chronic serositis. So later on, he had a worsening hypotension, after which and coagulopathy, which required multiple transfusion. But his sensorium improved, and later on, but he was extubated and kept on NIV. So in post-operative 20, he had a high drain output, and upper GI bleed was there. Which
Sorry, you have to summarize now. So why did we lose him?
Sir, later on, he had a worsening metabolic acidosis. He was intubated again due to poor respiratory efforts and poor sensorium. So, and he was difficult to wean, and we did a tracheostomy.
So what we could have done better? Could we have done something better? I think this guy had ABO incompatible. So were we monitoring the
So titers were all throughout the time. Titers were 1.
And the fungal infection didn't go anywhere else other than the bowel?
No, sir, fungal infection was in the bowel only, and lung.
Which is a bit unusual. Mucormycosis limited to. Did you review this? Limited to the bowel only, mucor, and not.
I also ask, was he a right candidate selected for the ABO incompatible transplant, considering the history in short span of time? He had multiple hospitalizations for infections, influenza.
Actually,
influenza is known to cause, so you may not have picked up this. It's known to cause superadded bacterial and fungal infections.
He was post-influenza. He had we waited and we optimized him, and we.
I'm saying ABO incompatible. Was this the right candidate to be selected? That is my question.
Dr. Mitchell, you want to say something?
Yes, sir. So yeah, I agree with Rakhi about this, that whether we should have actually transplanted him or not. But then we are stuck with the patient who was actually have been unwell for a while. He had multiple hospital admission. We have given him rituximab. I think in July we gave him actually.
August
or July.
Yes.
And then we were planning to do him. We got him in, and on the day he was admitted, he had fever and influenza. So then we waited for another month for influenza to get cleared up. And then by the time the patient and the family was obviously desperate. So we have a detailed discussion with them. Repeatedly had. Actually, I was repeatedly trying to avoid this transplant, not to do, but then family wanted to have it. There was a donor available in the family as well.
Let's go to the nephrology. We have nephrology now. Are they presenting? So while you are moving up very quickly, is nephrology presenting? I think here is 2 lessons probably, maybe ABO incompatible. The choice has to be more
in our patient population. What happens is most of the time this has been not where we're done, and then after rituximab patient have developed sepsis, and then they recover, and then they are looking up to you कि sir अब तो ठीक हो गया, अब तो कर दो, अब तो culture negative है, सारे 2 बार culture हो गए negative है, and then you're sitting there saying no. So that's where it gets stuck.
Many people are. I think we should have more experience. I mean, we shouldn't give up. Okay, nephro, please.
Can I just for the NRP? This is very good. The DCD donor we did. which was available in Manipal. This was first in Asia actually, where normothermic regional perfusion was done. This was a very hectic thing on that day for us to take that offer and do it, and patient did well. So this is actually, something which can give
We should,
momentum to disease donor transplant, and I think this should be.
We should take it up more.
Mhm.
Very good. Thank you. And I think it's a big achievement for our department to get it. I'm sorry we are limiting you with time, but hopefully you can complete quickly.
Good morning. I'll be presenting the mortality and morbidity data of nephrology of past 3 months. The admissions in August, September, October were 61, 68, and 69. Mortality were 1 and 3 respectively. And kidney transplants were done 3 in October. Total dialysis done in August, September, October were 1,070, 1,180 and 1,170. Coming to the morbidity, 34-year-old male, Mr. N, resident of Delhi, who was admitted on 21st of October and was admitted with complaints of shortness of breath for 20 days and fever on and off for 20 days. I would like to date back my history to 2018 when he was diagnosed to have a CKD, and his native kidney disease was undetermined, and he was started on medical management for CKD. Along with that, his AV fistula creation was done on the in 2018. Over 1 year, his CKD progressed and he had uremic symptoms for which HT was initiated through AV fistula in May 2019. Patient underwent a kidney transplant on live kidney transplant on 3rd of December 2019 at ILBS. Father was the donor, ABO compatible transplant, and the HLA mismatch was 2/6. There was no induction given for this patient, and maintenance immunosuppression for tacrolimus, MMF, and prednisolone was given. Nadir creatinine achieved was 1.04, and serum creatinine at discharge was 1.2. UPCR post-transplant was 0.7, and a patient had tuberculosis history, a pulmonary tuberculosis history, 9 months ATT he had taken post-transplant in 2022, and also he had post-transplant CMV viremia in April 2023. The treatment for that is he was lost to follow-up. Patient had proteinuria on routine evaluation in November 2022. He was advised for graft biopsy. However, it was not done at that time. Patient was then lost to follow-up between April 2023 to November 2023, and his creatinine increased gradually from 1 to 4 over a period of 1 year. In view of graft dysfunction and proteinuria, graft biopsy was done in January 2025. This was the kidney biopsy, which showed proteinuria, which showed recurrent and / de novo FSGS as a possibility of graft dysfunction. And this was the slide. So to summarize, in 2018, patient was diagnosed with CKD. In 2019, the hemodialysis was started, and in December, he underwent a live donor kidney transplant. In 2020, he had secondary AV fistula failure. In March 2022, he had pulmonary tuberculosis, and proteinuria began in November. In 2023, he had April, he had CMV viremia, and then he was lost to follow-up. In November, creatinine increased to 4. And in 2025, he had a graft biopsy and had uremic symptoms for which hemodialysis was reinitiated. However, from January to September 2025, he was again lost to follow-up. And on further asking about what he did, he said he was not on dialysis. However, he did not remove the tunneled cuff catheter, and it was in the place. So, patient presented to us with fever and shortness of breath for 20 days. On examination, he had tachypnea and had shortness of breath. Saturation was 86% and was connected to oxygen support. VBG showed lactic acidosis, and Day 1 investigation showed bicytopenia with sepsis, and total leukocyte count was 21. Procalcitonin was 100, and ESR CRP was 115 and 183. This was the Day 1 chest X-ray showing right tunneled cuff catheter with infiltrates, both in predominantly middle lobe and lower lobe, in right side more than left side. Provisional diagnosis: patient was diagnosed with bilateral pneumonia with sepsis, bicytopenia, query sepsis related, chronic graft dysfunction. FSGS query non-compliance to immunosuppressants, CKD5, and excess was right tunnel cuff catheter and non-compliant to dialysis. He was admitted to SICU and was started on meropenem teicoplanin. Hemodialysis was continued on alternate day. Pulmo opinion was taken and respiratory virus PCR was sent, which showed rhinovirus and enterovirus positive. CECT showed multiple bilateral effusion with multiple patches of consolidation in both lungs. DIC profile was done, which showed D-dimer 2700, fibrinogen was 372, and FDP was 5. Malaria and dengue were negative. This was the CT. Showing bilateral multiple patches of consolidation and mild bilateral pleural effusion was seen. Patient had gradual increasing O2 requirement and was later put on NIV support, and in view of septicemia and bilateral pneumonia, perm cath was removed. Cultures MC producing Pseudomonas aeruginosa was isolated from the perm cath hub on 24th, and Staph aureus methicillin sensitive, probably a colonizer, from the catheter tip was isolated. Sputum showed gram negative scanty bacteria growth and normal commensal flora growth. However, from the peripheral blood, carbapenem resistant Enterobacter cloacae was isolated on 27th, and so patient was shifted to ceftazidime avibactam and estrionam along with colistin, gentamicin, and empirical amphotericin B was started on day 5 in view of multiple bilateral patchy pneumonia. Galactomannan was 0.46. Hemodialysis was continued through the right internal jugular vein double lumen jugular catheter. Patient had persistent anemia and progressive thrombocytopenia, and multiple blood transfusions were given for the same. Echo was showing normal systolic function with moderate MR and mild TR. This was the serial X-rays, which showed worsening, and the catheter was removed on 26, and DLJC was put. Bicytopenia was worked up, and LDH was 512, B12 was 2000, folate was 20, DCT, ICT was negative, retic count was 1.2. Peripheral smear showed normocytic normochromic anemia with leukopenia and thrombocytopenia. Stool for occult blood was negative, parvovirus was negative, CMV was less than 200, EBV, PCR and serology was negative. Hematology opinion was taken and was advised for bone marrow aspiration and biopsy. This was the trend of hemoglobin and TLC count. From 21, it came down to 3,600. And hemoglobin was persistently low. It never went above 7. Platelet counts were also very low. In view of ARDS, dexamethasone was added. Patient had increasing O2 requirement, and pulmonology opinion was taken, and Ilores with moxifloxacin was added. Ceftazidime avibactam was stopped. Patient had
You
severe.
added dexamethasone in this patient.
Ma'am, actually the PF.
So you added Dextra. That must have killed the patient.
Ma'am, actually the patient was already on Visolon, and he was shifted to hydrocortisone. So dexamethasone at dose of 6 mg OD for ARDS was added. Bronchoscopy was done by Pulmo team, and bulk report showed galactomannan of 1.64. AFB stain, gene expert, fungal culture and aerobic culture was negative. Repeat ET secretions, galactomannan was 0.6. Repeat blood culture was sterile. However, the bicytopenia persisted and patient had bleeding from ET tube. RDPC transfusions were done, and he was continued on mechanical ventilator support. This was the further trend of hemoglobin, TLC and platelet counts. Platelet further
Can
dropped.
you summarize now?
Yes, sir.
Yeah. So he has infections, which is not responding.
Sir, infections were there. It responded after he was intubated, and chest X-ray improved. His post extubation, the patient again had fever with tachypnea, and the chest X-ray showed again the presence of bilateral infiltrates. And again, the culture showed Elizabeth Kingia meningoseptica, which is most likely a hospital-acquired infection. So our patient, this was a procalcitonin trend, which reduced to 13, and then it came about to
He is
50.
doing okay now. He's better.
No, sir. The patient has persistent sepsis with shock, and he is currently having melena, and along with that, he is having ET tube bleeding, and persistent pancytopenia is there, sir.
All right, so it still remains a challenge. I think, I'm sure. And he is cirrhosis,
No, sir.
so he's a non-liver disease patient
Yes.
otherwise. And, okay. Any comments, Dr. Mathurson?
सर के पास माइक जा रहा तब तक हाइड्रोकॉर्टिसोन सीवियर सेप्सिस में हाइड्रोकॉर्टिसोन इज इन गाइडलाइन isn't it?
Yes,
In
sir.
the bundle, right?
Yes, sir.
है ना?
I was asking about dexamethasone.
So, ma'am, it was usually, I mean, it's ADR, ARDS, so we switched to DEXA because
We don't give DEXA. I'm not sure where the guidelines are, but maybe you have in nephro some guidelines.
so it works better.
Works better. What about this patient?
So still this patient is in the ICU with in this condition. So I think so he has not been responding to antifungals and this has been a challenge because he's in post-transplant on immunosuppression and now landed up with this. He was non-compliant with the tunnel catheter for a long time, for like 3-4 months. So probably now it's become like a disseminated sepsis. It's not responding to any of the antibiotics. The catheter is out. So we wanted him.
I mean, I'm not sure immunomodulation with growth factors can be, but somebody has to very carefully look into it. Maybe we have opinion of Vikas or Pratibha, and maybe somebody from Dr. Daga or someone can also put in together.
Chandni, I have a question. There was CMV viremia initially, but in the BAL sample, did you look for the viral CMV pneumonia is very common? You've got it done? Okay.
Okay.
Not from the blood, from the BAL.
All right. Thank you all.
First.